Hello and welcome to the topic Luminal Indigestion or Chronic Pancreatitis in the module Gastroenterology and Hepatology. By the end of this topic, you should be able to define luminal indigestion, discuss the pathophysiology of luminal indigestion, explain the clinical presentation of a patient who comes in with luminal indigestion, outline the investigations to diagnose, and discuss the management of luminal indigestion. Let's get started. Chronic pancreatitis is a long-standing inflammation of the pancreas that alters the organ's normal structure and functions. It can present as episodes of acute inflammation in a previously injured pancreas, or as chronic damage with persistent pain or malabsorption. It is a disease process characterized by irreversible damage to the pancreas as distinct from reversible changes seen in acute pancreatitis. The pancreas is an organ located behind the stomach. It makes enzymes, which are special proteins that help digest food. It also makes hormones that control the level of sugars in the bloodstream. So the risk factors for chronic pancreatitis include a blockage of the pancreatic duct either by gallstones or pancreatic stones or cancer. Apart from that, you may want to consider hereditary diseases of the pancreas. Here, the mechanism of chronic pancreatitis is viewed from a genetic standpoint, indicating early onset of severe epigastric pain beginning in childhood. It is an autosomal dominant disease, and this chronic pancreatitis disease is identified in cationic trypsinogen gene and mutation. It is the most common mutation for hereditary chronic pancreatitis, with replacement of arginine with histidine at amino acid position 1 to 2 of the trypsinogen protein. This condition can also be in a form of autoimmune disease, which occurs when one's body mistakenly attacks the healthy cells and tissues instead. High levels of calcium, which is known as hypercalcemia, is also a risk factor. Hypertriglyceridemia, long-term alcohol abuse, as well as smoking. So here, pancreatitis occurs when the pancreas becomes inflamed. It is considered acute when the inflammation comes on suddenly and only lasts for a short period of time. It's considered chronic when it keeps coming back or when the inflammation doesn't heal for months or years. Chronic pancreatitis can lead to permanent scarring and damage. Calcium stones and cysts may develop in the pancreas, which can block the duct or tube that carries digestive enzymes and juices to the stomach. The blockage may lower the levels of pancreatic enzymes and hormones, which will make it harder for the body to digest food and regulate blood sugar levels. This can cause serious health problems, including malnutrition and diabetes. At first, one may not notice any symptoms. Changes in the pancreas can become quite advanced before one begins to feel unwell. When symptoms occur, they may include pain in the upper abdomen, excessive thirst and fatigue, unexplained weight loss, shortness of breath, nausea and vomiting, fatty stools which are loose, pale and don't flush away easily, and also diarrhea. For most patients with chronic pancreatitis, abdominal pain is a presenting symptom. The patient experiences intermittent attacks of severe pain, often in the mid-abdomen or left upper abdomen, and occasionally radiating in a band-like fashion or localized to the mid-back. One may experience more severe symptoms as the disease progresses, such as pancreatic juice fluids in the abdomen, jaundice, which is characterized by a yellow discoloration of the eyes and skin, internal bleeding, and intestinal blockage. Painful episodes can last for hours or even days, and some people find that eating or drinking can make their pain worse. As the disease progresses, the pain may become more constant. So how is chronic pancreatitis diagnosed? During the early stages of chronic pancreatitis, changes in the pancreas are difficult to see in blood tests. For this reason, blood tests typically aren't used to diagnose the disease. However, blood may be used to determine the amount of pancreatic enzymes in the body. Blood tests may also be used to check for blood cell counts along with kidney and liver function tests. A stool sample to test for levels of fat can be done. Fatty stools could be a sign that the body isn't absorbing nutrients correctly. Diagnosis is based on tests of pancreatic structure and function. Imaging studies can be carried out. For example, abdominal radiography and CT scanning can show inflammation or calcium deposits in the pancreas or changes in the pancreatic ducts. Pancreatic calcifications, often considered pathognomonic of chronic pancreatitis, are observed in approximately 30% of cases. Endoscopic retrograde cholangiopancreatography, or also known as ERCP, is a test that provides the most accurate visualization of the pancreatic ductal system and has been regarded as the criterion standard for diagnosing chronic pancreatitis. It combines the use of endoscopy and fluoroscopy to visualize and treat problems of the biliary and the pancreatic ducts. Next would be MRCP, or magnetic resonance cholangiopancreatography, which provides information on the pancreatic parenchyma and adjacent abdomen viscera, and it uses heavily T2 weighted images to visualize the biliary and pancreatic ductal systems. Next would be endoscopic ultrasonography. The most predictive endosonographic feature of chronic pancreatitis is the presence of stones. Other suggestive features include visible side branches, cyst, lobularity, an irregular main pancreatic duct, hyperechoic foci and strands, dilation of the main pancreatic duct, and hyperechoic margins of the main pancreatic duct. Last but not least, radiologic evaluation and drainage. Prior to percutaneous drainage, performing pancreatography is important in order to understand the anatomy of the pancreatic ductal system and plan appropriate treatment. If a communication exists between the pancreatic ductal system and the pseudocyst, percutaneous drainage may create a persistent pancreatocutaneous fistula, especially if the duct has a stricture downstream from the site of the disruption. Treatment for chronic pancreatitis focuses on reducing the pain and improving digestive functions. The damage to the pancreas can't be undone, but with proper care, one should be able to manage many of the symptoms. Treatment for pancreatitis can include medications, endoscopic therapies, or surgery. Possible medications that the doctor may prescribe for chronic pancreatitis include pain medications, artificial digestive enzymes if the enzyme levels are too low to digest food normally, insulin if one has diabetes, and steroids if one has autoimmune pancreatitis, which occurs when the body's immune system attacks the pancreas. Next would be endoscopy. Some treatments use an endoscope to reduce pain and get rid of blockages. An endoscope is a long, flexible tube that the doctor inserts through the mouth. It allows the doctor to remove pancreatic stones, place small tubes called stents to improve flow, and close leaks. Among the approach considerations that can be taken into account would be to modify behaviors that may exacerbate the natural history of the disease, to enable pancreas to heal itself, to determine the cause of abdominal pain and alleviate it, to detect pancreatic exocrine insufficiency and restore the digestion and absorption to normal, to diagnose and treat endocrine insufficiency, and the benefit of antioxidants in the early stages of chronic pancreatitis are still controversial, so most patients can be managed medically. Even in patients with asymptomatic pseudocysts, relatively few develop serious complications requiring urgent surgery. The choice of surgery depends on the clinical problem and the preoperative assessment of the abnormality. In general, the approach aims either to improve pancreatic duct drainage or to resect the diseased organs. In patients with dilated pancreatic duct, a row and Y side-to-side pancreaticojejunostomy is indicated. The operative mortality rate is about 3%, and pain relief is obtained in approximately 75% of patients. For pancreatic resection, if the disease is limited to the head of the pancreas, a Whipple operation can be done to produce good results. In patients with intractable pain and diffuse disease with non-dilated ducts, a subtotal or total pancreatectomy can be offered. A diet low in fat and high in protein and carbohydrates is recommended, especially in patients with steatorrhea. The degree of fat restriction depends on the severity of fat malabsorption. Generally, an intake of 20 grams a day or less is sufficient. So, what are the possible complications of chronic pancreatitis? Chronic pancreatitis has the potential to cause numerous complications. Nutrient malabsorption is one of the most common complications. Since the pancreas isn't producing enough digestive enzymes, the body isn't absorbing nutrients adequately, and this can lead to malnutrition. The development of diabetes is another possible complication. Pancreatitis damages the cells that produce insulin and glucagon, which are the hormones that control the amount of sugar in the body. This can lead to an increase in blood sugar levels. And finally, some people will also develop pseudocysts, which are fluid-filled growths that can form inside or outside of the pancreas. Pseudocysts are dangerous because they can block important ducts and blood vessels. They may become infected in some cases as well. So we have looked at chronic pancreatitis in terms of the definition, what causes and the pathophysiology, how do patients with chronic pancreatitis present, the important investigations that need to be carried out to diagnose as well as to assess the severity of the disease, to assess the complications as well, and management would include medical as well as surgical approach in order to alleviate pain as well as to remove the part that's diseased. We have come to the end of this topic. Thank you.